My name is Kyle Dayton, and the aim of my literature search was to determine if task-specific training is an effective intervention for improving upper extremity function in patients who have had a stroke. This is an important topic to address as we will encounter many patients who have had a stroke, and it is vital that we are providing them with an intervention that is backed by research. The first article that I reviewed was by Winstein et al. This study demonstrated level 1 evidence and utilized a single-blind randomized clinical trial. There were a total of 361 participants in this study. The intervention group consisted of 119 participants who received a task-specific training program for the upper extremity called Accelerated Skill Acquisition Program, or ASAP, for 1 hour a day, 3 days per week for a total of 10 weeks. There were two comparison groups. The first consisted of 120 participants who received dose equivalent to usual and customary care for the same duration as the intervention group. The second comparison group received usual and customary care with no limit on the number of outpatient therapy sessions they could attend. The researchers concluded that there was no statistically significant difference between groups, but all three groups demonstrated improvements from their baseline. This study was limited by the fact that the researchers did not take into consideration that spontaneous recovery may have had an impact on outcome measures. The dosage of the therapy may have been a little too small, and the term standard care is vague as care is constantly changing over time. The second article that I reviewed was by Aria et al. This study demonstrated level 2 evidence and used a double-blind randomized control trial. There were 103 participants in this study, with 52 in the intervention group and 51 in the comparison group. The intervention group received meaningful task-specific training 1 hour a day, 4 to 5 days per week for 4 weeks. The intervention group received the Bobath neurodevelopmental technique and the Brunstrom movement therapy technique for the same duration as the control group. The researchers found significant improvements on the Fugl-Meyer assessment, action research arm test, and the motor activity log. The graded Wolf motor function test showed improvement at a follow-up assessment. The researchers concluded that the intervention for the control group showed superiority over the comparison group's intervention. This study was limited by the fact that all interventions were conducted in the same center. Assessors did not have a significant background in distributing the assessments, and the researchers did not consider the effect of time, age transference, and interference on neuroplasticity. The third article that I reviewed was by Wolf et al. This study demonstrated level 2 evidence and used a single-blind randomized clinical trial. There were 35 participants in this study, 19 in the intervention group and 16 in the comparison group. The intervention group received cognitive orientation to daily occupational performance, or co-op, for a maximum of 10 days, followed by standard OT treatment. The comparison group received standard care from an occupational therapist, though the duration was not reported. Participants showed improvements on all outcome measures involved in this study at post-intervention and at a follow-up assessment. The researchers concluded that task-specific training is a superior intervention strategy when compared to standard occupational therapy, and there were limitations to consider in this study. The study used a small sample size. The participants receiving co-op also received standard occupational therapy. The comparison group had dropouts, and the participants receiving usual care were treated at different locations, possibly leading to slightly different treatment techniques. The final article I reviewed was by Fleming et al. The research demonstrated level 2 evidence and used a double-blind randomized control trial. There were 33 total participants, 17 in the intervention group and 16 in the comparison group. The intervention group received somatosensory stimulation for 12 2-hour sessions, followed by 30 minutes of task-specific training, while the comparison group received sham somatosensory stimulation with severed leads so that no electrical impulse could pass through, and then followed by 30 minutes of task-specific training. The researchers found significant improvements seen on the goal attainment scale and action research arm test in favor of the intervention group. Based on these results, they concluded that the TST combined with somatosensory stimulation is a more effective intervention for improving functional ability, impairment, and arm use than just TST alone. This study is limited by the fact that they did not monitor whether or not participants in opposing groups communicated with one another. Assessment scores may have been skewed since only one researcher scored them, and the researchers did a poor job calculating the power of the study. The quality of the literature available is somewhat limited because of small sample sizes and inadequate research designs. It's important that we continue building on the current research to ensure that we are employing quality evidence-based practice.